Hello, everyone. This is Dr. Mikky. I'm recording a lecture on Chapter 48 for Pathoform 2, and it's on the drugs for bone and joint disorders. And in this lecture, we are going to um, highlight and discuss the diseases that are associated with osteoporosis, osteomalacia, Paget's disease, which is known as a metabolic bone disorders. In addition, also to this will be other conditions or related conditions to the system, which is the infection that involves the bones, which is osteomyelitis, and connective tissue disease like gout. And after that, we'll discuss some concepts and disorders that involve the bone, like fractures and the modalities, how to treat, bone fractures and medications to treat osteoporosis to prevent the fractures in which that will make the bones more solid and more strong. So the chapter starts with begins with the role of the calcium and vitamin D in bone homeostasis, and in which that we have covered this in different topics or sections of the endocrine system. And we went over the mechanism, how the hypothyroid, the parathyroid hormone, PTH hormone, controls the calcium level. When the patient develops the hypocalcemia, that's when the parathyroid hormone will be prompted to or be stimulated to produce more of the PTH hormone to control the hypocalcemia by pulling some of the calcium from the bone, enhancing the absorption of calcium at the GI level system, and also works on the kidneys to increase reabsorption of calcium and decreasing the calcium release or being lost in the urine, which is calcium excretion. So it increases at the renal level or kidneys. It will increase reabsorption of calcium and decrease calcium excretion. So that's how the PTH hormone will control the hypocalcemia, and it will bring the potassium level back to normal levels, which is called the calcium and vitamin D homeostasis. The kidneys also has a significant role on the activation of vitamin D, and that will be also explained in the upcoming slides. Another figure of the feedback mechanism, which is a negative feedback mechanism for the or between the parathyroid hormone and calcium, and how PTH hormone controls the calcium level in the blood. This slide also keeps on or continue to discuss the same concept of calcium and vitamin D homeostasis, which has been covered in previous sections of the endocrine system. The recommended dietary allowance or RDA of calcium, it's about 800 to 1200. That's for adults daily, milligrams daily. The normal level for calcium, it's 8.5, or some textbooks will go to 9, and then up to 10.5 or 10 milligrams up to 11 milligrams. So it can be 8.5 to 10 or 9 to 11 milligrams. That's the normal calcium level, but the active form, which is the ionized calcium is less than that. It's half of this, which is about 4.5 up to 5.5 milligrams. So the hypocalcemia, when the patient develops the hypocalcemia, that would result from a serum calcium level when it drops below 8.5 milligrams, or the hypercalcemia. That's when the calcium level exceeds the highest level, which is 9 or 10 milligrams. The role of calcium in maintaining homeostasis, too much calcium or too high calcium hypercalcemia, it will lead to decreased sodium permeability across the cell membranes. And then the hypocalcemia, which is too low calcium level in the blood, it will result in a cell membrane to become hyperexcitable, hyperexcitation of the cell membrane, and convulsions or muscle spasm would result from the hypocalcemia. So the calcium salts are is the treatment for the hypocalcemia. So it's to return serum calcium level back to normal. We will have, we'll give you the calcium supplement, and it's used to prevent and treat mild hypocalcemia or for osteoporosis, Paget's disease, chronic hypoparathyroidism, in pregnancy also with hypocalcemia so it's hypocalcemia, pregnancy-related hypocalcemia, in other words, during lactation, and then rapid childhood growth. That's the primary use of this calcium supplement. So however, the IV form, the IV administration of calcium may cause hypotension, bradycardia, dysrhythmias, and cardiac arrest. So that's a significant concept about the hypocalcemia. So let's go back and review. So for mild chronic hypocalcemia, we prescribe the calcium supplements that are effective and that are readily available over the counter OTC drug in a variety of formulations. Calcium carbonate, calcium citrate. These are the two most common salts for routine supplementation of calcium. So when you prescribe calcium, in addition, it's to preventing or treating hypocalcemia. Calcium salts are administered for osteoporosis, osteomalacia, chronic hypoparathyroidism, during pregnancy, lactation, as we said, and rapid childhood growth. Also, the calcium carbonate is a common antacid. It's an antacid to treat heartburn. And sometimes they combine, or it may also be the calcium carbonate may also be used to bind the excessive dietary phosphate in patients with hyperphosphatemia due to the end-stage renal disease. So patients with end-stage renal disease, renal failure, on dialysis, most likely they will be on dialysis, they will benefit from calcium carbonate. So because that calcium carbonate will get rid of the excess of phosphate. So it will take care of the hyperphosphatemia because the calcium carbonate will bind to the phosphate and that will be released or removed from the blood that way. So that will be the best way to get that phosphate out of the blood or from the blood in patients with end-stage renal disease, because they have hyperphosphatemia due to that renal failure. The calcium carbonate will be a good treatment for that. For severe cases of the hypocalcemia, then we will give a multiple IV infusions of calcium salts, calcium gluconate, for example. An example of calcium salts. So for the PO, we give the oral calcium supplements with meals or within an hour following the meals. The IV supplement of calcium to be given slowly so we can avoid hypotension, serious cardiac dysrhythmias, cardiac arrest. Because if given too rapidly, it can cause these problems. It may result in these issues, serious conditions. Also, the IV calcium gluconate, it's a drug that can cause extravasation and irritates the blood vessels and result in necrosis and sloughing of the blood vessels and tissues around the blood vessels. So if the extravasation occurs, then we will give a drug, hyaluronidase, amphidase, or phytrase. That's the drug is usually prescribed to treat the extravasation. If that, if extravasation occurs when we use the IV calcium gluconate. So the calcium salts are contraindicated in patients with ventricular fibrillation, VFib, metastatic bone disease, with kidney renal failure or calculi. Patients with hypercalcemia should not be given any calcium because that will result in more renal calculi, renal or kidney stones, and more dehydration. So it's the interaction, so drug-drug interaction, the calcium, the concurrent use with digoxin will increase the risk of dysrhythmias. Magnesium may compete for GI absorption. The calcium decreases the absorption of tetracyclines. And the calcium may antagonize the effects of calcium channel blockers, the CBB drugs. And the calcium may increase, the value of, or the blood pH and serum calcium will be, elevated due to the excess calcium or calcium supplement use. And it may decrease serum phosphate and potassium levels as well. It will decrease. In this case, it will decrease phosphate and potassium levels. So the first so before we get to the osteoporosis, for the IV calcium gluconate, we have a specific protocol. Most hospitals, they have a specific protocol for the use of IV calcium gluconate, that it should be administered into a large central or deep vein. It should always be given slowly, as we said, and not to exceed 1 milligram, 1 ml per minute, 1 ml per minute, not to exceed this. Patients sometimes may complain or might complain of a hot feeling of the skin or tongue. And for when extravasation occurs, then we said we have, we'll inject the hyaluronidase drug, and that's usually it's diluted into like 1 to 10 dilution in a 150 unit vial. And you will learn about this in Adult Health 3, about the specific dilution and how to mix the drug and how to be administered and how many times, the frequency of using the drug. Also, all this will be learned and uncovered in Adult Health 3. Now, moving to the next topic, which is osteoporosis, which is chronic progressive metabolic bone disorder or disease. And this metabolic bone disease, in which the characteristics of this is that the bone becomes porous low bone mass, and structural deterioration of the bone tissue. And this is one of the most common MBD, which is metabolic bone disease. It's more common than the osteomalacia or Batch's disease, the osteoporosis. So this disease is related to bone deterioration, as we said, in which that the bone resorption outpaces or outweigh the bone deposition. So the bone deposition, the deposition of the calcium into the bone, it will be faster than the bone resorption, which is resorption means pulling the calcium out of the bone. So calcium getting into the bone is faster than coming out of the bone. The bone removal, which is the bone resorption, is faster and it outweighs and it outpaces the bone deposition. So, which means that the bone will lack the calcium, will lack deposition, will lack the strength, will lack the bone mass will be less. So there will be a lack of dietary calcium and vitamin D and disrupted bone homeostasis. And we have at least here 5 reasons and rationales for why women are more susceptible to develop osteoporosis than men. And you can read through, and see why women are more susceptible, than men and getting the osteoporosis or affected by the osteoporosis disease. Now, the etiology and pathophysiology is all risk factors. I have too many risk factors. The most common ones, other than the gender-related, which is like when we say, female gender, the first one is that it's associated with the both age groups, which is the early menopause, the most common risk factor, and also the postmenopausal factors. That's when the estrogen and progesterone, which is protective for the bone, these hormones are going to be extremely lower than the postmenopausal phase. So the other factors, the most common factor will be female gender, and then you can it's the drug related, like medications that will lower the calcium in the blood, like patients on, for example, corticosteroids, anticonvulsant medications, immunosuppressant drugs. All these drugs are known to lower the bone density, the bone mass, and to affect the bone resorption and calcium deposition will be less, so that will result in osteoporosis. So bone resorption exceeds, which means all these factors will result in the fact that in osteoporosis, because the bone resorption again exceeds the bone deposition. Bone resorption again is the removal of calcium from the bone. It will exceed the bone deposition. So the osteoporosis, a common metabolic disease characterized by decreased bone strength, low bone mass, and skeletal fragility, and results in a high risk for fractures. And that's the most dangerous, serious condition that could result from the osteoporosis. That's any falls or injury could result in fracture, or any minimal trauma sometimes result in fractures because the bone is fragile, the bone is weak, so it's not that strong or it's not solid. So most common among this group. So we have included here all the most commonly affected groups, including the lifestyle, like the tobacco, alcohol, and in addition to the steroid use medications. So the patient clinical presentation, the history of eradication of abnormal TSH level raised suspicion for malignancy. So that's why the ultrasound of the thyroid would be done to isolate the nodules to be screened for thyroid cancer by fine needle aspiration. So in other words, that here is that some type of osteoporosis related to the TSH and thyroid malignancy. Clinical manifestations, it's known to be termed as a silent disease because there are no symptoms. Patient is asymptomatic until the patient is presented with like hip fractures, verbal compressions, um, fractures result, in loss of high progressive thoracic kyphosis. So these are some of the long-term complications that patient will develop over time, and then all of a sudden patient has fracture from minimal trauma, for example. That is an example of patient has been never diagnosed with osteoporosis, but been having this osteoporosis problem. That's why diagnosis needs like continuous evaluation. And one of the evaluations is, and it's recommended, which is a DEXA X-ray. It's the dual energy X-ray absorptiometry, and the DEXA is the gold standard to diagnose patients with osteoporosis. So in diagnosing patients with osteoporosis, also when we get, the DEXA will give us what is called the T-score. T-score. And the T-score, based on the T-score, we can determine the level of involvement of this disease in terms that we can say that patient has an osteoporosis or, normal bone is, no osteoporosis, or patient has a low bone density or osteopenia, or the patient has an osteoporosis or severe osteoporosis. And this will be according to, as we read the DEXA numbers and values of that, what is called the T-score. And this will be also, again, covered in adult health 3. And the normal score of T-score normally should be higher or equal to or higher than minus 1.0. And the next step will be osteopenia. The next level will be osteoporosis, and the highest level will be severe osteoporosis. An example of this, for example, the severe osteoporosis will be diagnosed when the patient's T-score is less than minus 2.5 with fractures. So the DEXA level or T level is going to be less than minus 2.5, plus patient has developed a fracture. So combining the T-score with the fracture, we can diagnose patient with severe osteoporosis. This is an example of how to diagnose patients with osteoporosis using the DEXA results, which is called the T-score. Again, we'll go over this in adult health 3. Osteomalacia, which is a MBD, metabolic bone disease characterized by softening of the bone due to demineralization, less calcium getting into the bone. Most frequent cause of osteomalacia is the deficiency of vitamin D and calcium in the diet. Hypocalcemia and less or decreased RDA of vitamin D or calcium or both can result in this disease. And in the US, it's most prevalent in the older adults, in premature infants, and in individuals on strict vegetarian or vegan diets. So the symptoms or clinical manifestations of osteomalacia will include hypocalcemia, muscle weakness, muscle spasms, diffuse bone pain, especially in the hip area. And the classic signs of rickets in children, in which that the children will have the bow legs and the pigeon breast, and the children may also develop a slight fever and become restless at night. That's kind of signs of the hypocalcemia when the children are they will have diagnosed of have signs, classic signs of rickets. Pharmacology treatment will be supplement of calcium and vitamin D. Calcitriol is used in treating rickets, and then calcitriol usually prescribed, and which is a form of vitamin D, active vitamin D, calcitriol. Also, it's prescribed in combination with calcium supplements. So you can give vitamin D, but it should be given always with calcium supplement, because we know that the calcium, what promote the calcium absorption is the vitamin D. So the recommendations is the daily calcium vitamin D and an adequate exposure to sunlight, especially in the morning. Badger's disease. It's also called the osteitis deformans, another name for Badger's disease. This chronic condition characterized by accelerated remodeling of the skeleton, result in enlarged and softened bones. Now, the processes of bone resorption and bone deposition occur simultaneously, both at very high rate. So the rate of bone resorption and bone deposition, it will occur simultaneously but at a very high rate. So the rapid turnover of both bone resorption and bone deposition causes new bone to be weak, brittle, fragile, and will result in deformities and fractures. The cause of the disease is unknown, so the etiology, we didn't have any identifiable cause or etiology for this disease, but we know about the clinical manifestation. Although many patients are asymptomatic, but about 10 patients may experience vague, non-specific complaints that will include pain of the hips, femurs, joint inflammation, headaches, sometimes facial pain, hearing loss, and that's when the bone around the ear are affected. Nerves along the spinal column may be pinched because of the abnormal vertebral bone growth. Remember, we said that both processes of bone resorption and bone deposition, they occur simultaneously at very high rate, which will eventually result in a new bone that is weak, brittle, fragile, and may result also in deformities and fractures. So the treatment, if diagnosed early enough, symptoms can be treated successfully. Now, if diagnoses are made or is made late in the progression of the disease process, then permanent skeletal abnormalities will develop and other disorders may appear, including arthritis, kidney stones, and heart disease. So the treatment, again, for the osteoporosis, and also that will be again for osteomalacia or just because there's we need more calcium. So this is all about the calcium supplement. These in the following slides are about the calcium at the source, the good source of calcium and the poor source of calcium. So you'll be surprised that some we have known this for sometimes for long time, that some of these sources are like really good sources of calcium. So for example, most people think that the eggs are good source of calcium, and you will find that the eggs are a poor source of calcium. But the good sources are milk products, green leafy vegetables, seafood, almonds, and hazelnut. And the rest, in the top, are all the poor sources of calcium. So again, the supplement of vitamin D maybe recommended. Also the exercise. So here on this slide we'll go beyond the vitamin D small collaborative care, which will include even lifestyle change modifications, exercise. And so the exercise should be encouraged to build and maintain bone mass. Lifestyle modifications, patients should be instructed to quit smoking or cut down on alcohol intake to decrease losing bone mass. Now, drugs, medications are listed under these categories. The first one is estrogen replacement after menopause, which is hormone replacement therapy, HRT. With some recommendations, should be when they prescribe the HRT, should be within guidelines, and they have to follow the guidelines, and the specific regulation should be followed. Given that if you want to refer, I would refer you to read about the Women's Health Initiative, WHI, and which includes all the risk factors and all the complications that has resulted from the using the HRT, regardless of health conditions and diagnosis and so forth. So it's another important topic. It's called the health replacement therapy, like estrogen and progesterone therapy, for postmenopausal women. And this estrogen replacement therapy after menopause is no longer given as primary treatment to prevent osteoporosis. In the past, back in the 80s, I believe, or 90s, that there was a women's health initiative that came to kind of discuss this proposal, in which that they were prior to that they were prescribing the health replacement therapy for all postmenopausal women. They found that these women, there was a high rate of MI, cardiac disease, DVTs, and thrombosis that resulted from the estrogen and progesterone treatment. So then it's no longer the primary treatment to prevent osteoporosis due to the associated increased risk of heart disease and breast and uterine cancer. Calcitonin, which is a subcutaneous or nasal drug. The biphosphonates is the most commonly prescribed indications to treat osteoporosis. And this is the group of drugs we need to discuss and go over and make sure that we understand how to, what are the nursing implications when we administer the drug. So we have the biphosphonates. They inhibit the osteoclast-mediated bone resorption. The most commonly used ones are the Actonil, Fosamax, and Boniva. So the dronate prefix is another indication in which that you can identify these drugs: dronate, risedronate, alendronate, ibandronate. So the dronate is the suffix for for these drugs. So we can identify the biphosphonates by the dronate. You can tell this is suffix, and then I would say that this is a biphosphonate. So again, the three highlighted ones, which is Actonil, Fosamax, and the Boniva, the most highly prescribed and most commonly prescribed medications. So what do you need, or we have to know about this is that we will instruct the patient to take it with a full glass of water. So give it with a lot of lots of fluids, especially water, and then he will take the drug 30 minutes before food or other medications. And then patient should remain upright Not necessarily has to be like standing, but at least not like should be 90%, 90 degrees sitting. So the angle is important, not to be like, no, not even a 45 or 30 or like, lying like, flat, but most we would recommend to be like a sitting position, like 90-degree. So upright position for at least 30 minutes after taking the drug. What they found is that, this is the, evidence-based practice that they found that patients who have not followed the guidelines or recommendations and they for the upright position and took too much took the the enough or sufficient water or took the drug so did not take it before food like meals or other like we usually give it in the morning, so it should be given like before breakfast. So the three main points is that to give it with the fluids, full glass of water, so the fluids. Second point is timing, so 30 minutes before food or other medications. And the third point is the upright position. Fluid, time, upright position. Those, evidence-based practice found that patients who had never like, non-compliant with these recommendations, they developed esophageal cancer. Even though it's kind of difficult to explain the disease process, but at least that they found some association between, patients who are non-compliant with these recommendations and guidelines and patients who develop the esophageal cancer. That's why it's really critical that we instruct the patients to follow these guidelines. So the other medications will be the selective estrogen receptor modulators, SERM. It's called SERM or SERM acronym, SERM group of meds, and the most commonly used one is the Avista, Roloxifene, Avista. So vitamin D, which is calcitriol. We know that there are too many forms of vitamin D. Some short names, some other formulation. Formula will be like a long, extremely long name. So another hint to how to identify the vitamin Ds are by calcitriol. Whenever you see calcitriol or citriol, especially calcitriol, you will find that that's the suffix for all vitamin D supplements. So the effectiveness of calcitriol, we know that. So first of all, mechanism of action. So it's the vitamin D, calcitriol. It's an active form of vitamin D, promotes the intestinal absorption of calcium, and it reduces the bone resorption, elevates the serum levels of calcium. Primary use is patients with hypocalcemia, but should be the primary use for this one should be impaired kidney function or hypoparathyroidism. And also it can be used to treat, for treatment, and very useful for treating patients or children with rickets. Adverse effect will be hypercalcemia, headache, weakness, dry mouth, thirst, increased urination, muscle, bone pain. These are some of the side effects of the drug. So the effectiveness of calcitriol depends on the adequate amount of calcium. So that's why it is usually prescribed in combination with calcium supplement. You can't just give that vitamin D without giving. So usually it is given and prescribed in combination with calcium supplement. And it's available as the oral tablets and solutions and IV drug as well. So again, vitamin D therapy may cause symptoms of hypercalcemia, and the early symptoms of hypercalcemia as a side effect it would include the weakness, infusion, anorexia, nausea, vomiting, and the later signs of hypercalcemia include increased urination, polyuria, dysrhythmias, dehydration, weight loss. So at first sign of hypercalcemia, vitamin D therapy should be discontinued. And then daily calcium levels should be obtained until hypercalcemia is resolved. That's in patients who may develop the hypercalcemia. Now, drug-drug interactions. So first of all, the drug should not be given to patients with hypercalcemia or with evidence of vitamin D toxicity. Now, for drug-drug interaction, the thiazide diuretics may enhance the effects of vitamin D and cause hypercalcemia. Too much vitamin D may cause dysrhythmias, in which are patients who are receiving digoxin. So patients who receive digoxin, they will be affected by this. Too much vitamin D may cause dysrhythmia in patients who are receiving digoxin. Magnesium antacids or supplements should not be given concurrently, simultaneously, due to increased risk of hypermagnesemia. Now, biphosphonates, back to the biphosphonates, we said that, it's one example of prototype drug will be the alendronate, which is Fosamax. And this drug is the indications, prevention and treatment of osteoporosis in postmenopausal women. Also, we can, is prescribed to men and women both for all patients for the treatment of steroid or corticosteroid-induced osteoporosis. So patients on steroids, both women and men, who are on the long-term steroid therapy to prevent osteoporosis, we can prescribe Fosamax to prevent osteoporosis related to that. So it's the treatment of corticosteroid-induced osteoporosis in both women and men. Now, treatment also to increase bone mass in men with osteoporosis. In addition to also, it can be prescribed for patients with a symptomatic Paget's disease as well. Now, the drug, there are several regimens for alendronate Fosamax that are available as a prescription drug. Now, once daily, which is 10 milligrams, twice weekly, 35 milligrams, or once weekly, which is 70 milligrams. Although the once weekly regimen is more convenient, higher doses can result in an increased incidence of GI-related side effects. So again, all doses must be taken on an empty stomach, preferably in a fasting state of 2 hours before breakfast. We said, 30 minutes but at least just, 2 hours is the most safest kind of time frame before breakfast in the morning. And therapeutic effect of alendronate may take long time, 1 to 3 months to appear, and may continue for several months after therapy is discontinued. So again, therapeutic effects of alendronate's Fosamax may take 1 to 3 months to appear and may continue for several months after therapy is discontinued. Fosamax plus vitamin D combines alendronate and vitamin D into a single tablet. There is some forms of Fosamax plus vitamin D, but again, the discussion of or the nursing implications about Fosamax is critically important to be instructed or educated to the patient. So the adverse effects, we said it's include diarrhea, constipation, flatulence, nausea, vomiting, metallic taste, hypocalcemia, hypophosphatemia, abdominal pain, dyspepsia, arthralgia, myalgia, headache, rash. Now, the pathologic fractures, which is the fractures that will result from, it's called pathologic fractures. These fractures that will result from a fragile, soft, osteoporotic bone. So pathologic fractures may occur if the drug is taken longer than 3 months, or in cases of chronic overdose. Now, SERM, or the selective estrogen receptor modulators, this group of meds, the decrease bone resorption and increase bone mass density, may be either estrogen agonist or antagonist. Estrogen hormone, agonist or antagonist, depending on the drug or tissue involved. And the prototype drug is for this group is raloxifene, Evesta. Mechanism of action, it just decreases bone resorption because it will increase bone mass and density by acting through estrogen receptors. So the adverse effects, hot flashes, migraine, headache, flu-like symptoms, endometrial disorders, breast pain, vaginal bleeding, may cause fetal harm to the fetus when administered to pregnant women. So this drug is from the SERM group. It decreases bone resorption and increases bone mass or deposition and density of the bone mass by acting through the estrogen receptor. And it's primarily used for the prevention of osteoporosis in postmenopausal women. That's the most important indication for this drug, which is prevention of osteoporosis in postmenopausal women. So although the drug reduces the vertebral fractures caused by osteoporosis of the spine, it does not appear to reduce the incidence of fractures at the non-vertebral sites. So it's good has been proven to be effective to prevent fractures involving the spinal vertebral fractures or the vertebral spine. But the non-vertebral sites, this drug has not proven to be effective to treat the non-vertebral sites or the fractures at the non-vertebral sites. So it's very important to know that the pregnancy category for this drug is X. You can be given with or without food. It's a serious point here. The adverse effects. The most common adverse effect of the raloxifene Evista, we included all of them in previous slide, and we highlight all of these adverse effects in the previous slide, especially with the hot flashes, leg cramps, weight gain. These are the most, I would say, the most common ones. The hot flashes, leg cramps, and the weight gain. There are other signs that are less common effects, which like, fever, arthralgia, depression, insomnia, chest pain, peripheral edema. These are less frequently occurring as side effects, but the most common ones are the hot flashes, leg cramps, and weight gain. So, black box warning: the drug increases the risk of thromboembolism and blood clots, death from stroke, especially in women with CAD, coronary artery disease, or who had developed or with a history of thromboembolism, a DVT, pulmonary embolism, stroke, history with that. This one will be at high risk for the blood thrombosis and death from strokes. And there should be also a contraindication. So this drug, first of all, that's contraindicated during lactation and pregnancy, and in women who may become pregnant. In addition to that, patients with a history of venous thromboembolism or who are hypersensitive, sensitive to raloxifene should not take the drug. So concurrent use of the drug with warfarin, Coumadin may decrease prothrombin time, PT. Ampicillin or cholestyramine, the decreased raloxifene Evista absorption will result from concurrent use of the Evesta with ampicillin and cholestyramine. Decreased Evesta or raloxifene absorption will result from concurrent use of this drug with ampicillin and cholestyramine. And also the use of raloxifene Evesta with other highly protein-bound drugs, ibuprofen, indomethacin, diazepam, may interfere with binding sites. Calcitonin increases bone density and reduces the risk of vertebral fractures. The case study. So after you read the case study, highlight, I did highlight some of these significant statements or hints from the case study that are associated with the osteoporosis, and the answer to this one would be the DEXA. DEXA is fairly new, least expensive, and the quickest method, fastest method of assessing the metabolic bone disorders, BMD, like osteoporosis. So the precision of is very precise diagnostic tool or study. So the precision of the DEXA is approximately even it's 1 to 2%. The plain film is standard radiology. When you see plain film, which is like an X-ray. It's inadequate for accurate bone mass assessment. The single photon observometry is used to scan bone, which is a superficial location with little adjacent soft tissue. It may not be accurate reflector of the density of the spine or hip. So this one, maybe, this question is kind of beyond or above the scope or, of this class, and like it's an adult health 3 level. But the DEXA is the point from this is that, or the significant point is that the DEXA is the gold standard to diagnose patients with osteoporosis, and to detect and monitor the osteoporosis over time. Because the other diagnostic testing, they are not of that precision and the specialty like the DEXA diagnostic test. Like the CT, for example, it will expose the patient to more radiation, and no need for that, especially significant increase. Also, it's very, it's costly, very, it's increased cost, and also compared to DEXA is more expensive. So, all these, details about, difference between all of these diagnostic testing or modalities will be discussed in detail 3. Now, question number 2, which has to do with the lifestyle modifications. The answer is C, cigarette smoking. So the major risk factor for osteoporosis are family history, the early menopause, sedentary lifestyle, cigarette smoking, medications like steroids or corticosteroids, alcohol, caffeine, and low calcium intake. So C will is reflecting that concept. And then question number 3, which is relevant to question number 2, in which the answer is to stop smoking. It's like a continuation from question number 2. Question number 4, the answer is alendronate, which is the Fosamax, which is biphosphonate, which is approved for prevention and treatment of postmenopausal osteoporosis. Among the many results of what I have mentioned earlier, which is Women's Health Initiative, it was found that the combined estrogen plus progesterone hormone, which is called the hormone replacement therapy, HRT, was associated with an increased risk of non-fatal MI or deaths from coronary artery disease. So consequently, while it is recognized that postmenopausal women who are taking estrogen to alleviate and decrease postmenopausal symptoms may also experience skeletal benefits, the prevention of osteoporosis should not be a reason in itself to start estrogen therapy. So in the past, as I said, they used to prescribe the hormone replacement therapy for almost like the majority or even all the postmenopausal women, or women for postmenopause. But the calcitonin, so the alendronate, and then the calcitonin, it's a drug that inhibits the osteoclastic bone resorption, but is not sufficiently strong and potent to prevent bone loss in early postmenopausal women, which is within 5 years of menopause. So it is best reserved for use, the calcitonin, in patients with osteoporosis unresponsive to other therapies. Patients are responsive to all other therapies. They can be a candidate for calcitonin. The roloxifene Vista is a serum, as we said. selective estrogen receptor modulator, and it's effective for prevention of bone loss in early postmenopausal women and treatment of established osteoporosis. But it also increased the risk of VTE, venous thromboembolism, which makes it an appropriate choice for this patient. Now, the answer for this question is 10-year use of budesonide or Pulmicor, which is a nasal spray drug. So the long-term use of the corticosteroid like the budesonide, which is Pulmicor, should be identified as the risk factor for osteoporosis. Pipiaspirin is a cardioprotective if a drug and has not been identified to cause bone loss or osteoporosis. The Stelipram, which is Lexapro, antidepressant, has not been identified as to cause bone loss or osteoporosis. Same thing for calcium and vitamin D supplement that's helpful to prevent bone loss. The answer to this question is it's a multi-answer question. So select all that apply. You will say hyperthyroidism, postmenopausal, Asian race, and 62-year-old female. So all but C. Too much thyroid hormone can cause bone loss. And you can refer to the hyperthyroidism and see the association between hyperthyroid and calcium. The estrogen levels decrease at menopause, and this decrease one of the strongest risk factors for osteoporosis. So estrogen decrease is one of the strongest risk factors for osteoporosis. And then D, major risk factor for osteoporosis include white or Asian race, not an African American. E, the advanced age and being female are both risk factors for osteoporosis. Osteomyelitis, which is the severe infection of the bone marrow or surrounding tissue around the bone, soft tissue around the bone. The etiology and pathophysiology. Now, the pathophysiology is when there is any invasion of the listed here on this slide, the microorganisms, and that's all bacterial here. So an invasion of the microorganism can result either from the indirect mode or indirect entry or contiguous. Now, the indirect, which is endogenous or hematogenous, which is the most common type, then we have the exogenous, which is the direct entry, and then the contiguous, which is an example would be like, the infection result from skin infection of adjacent tissue or like periodontal infection, for example, dental infection and then bone infection. Direct entry, exogenous, fracture, and then results in direct entry from the fracture, an open wound, then the bone getting infected, that's a direct entry. Indirect entry, which is the most common one, which is like endogenous. Another example, one example would be an example of this patient with like kidney stones and then renal infection or UTI, severe UTI, then septicemia and sepsis, and then the osteomyelitis. Or infection and any systemic infection, and then or sepsis or septicemia, and then bone infection. So this is an example of the indirect one. And direct one was exogenous. That's from like an invasion of outside or bacterial or microorganism that can invade the bone exogenously, like open wound, fracture, then or open wound into the bone. That's an example. Even sometimes diabetic wound, like deep diabetic wound, or sacral wound, stage 4, for example, sacral wound. That's or the the cubitus ulcer, stage 4, because that affects the bone. So if that results in osteomyelitis, that is a direct entry. So the pathophysiology, it's somehow it's complicated, given that the bacteria. So first of all, um, let's just go back to the indirect and the direct entry and the contiguous. The indirect entry, hematogenous, it's more frequently affects growing bone um, in boys less than 12 years old, and also is associated with a higher incident of blunt trauma, bacteremia like UTI, long-term IV use, like long-term IV catheters, hemodialysis, long-term hemodialysis, IV drug abusers, for example, salmonella infections of the GI tract. Some of the direct entry would be at any age where there's an open wound, a punctured wound, animal bites, bone surgery, sometimes even surgical procedures with result in a complication or post-op like infection, especially with the implant or orthopedic or prosthetic device implanted, then results in a post-op with infection that could result in a osteomyelitis. Now, the pathophysiology, so microorganism entry, the microorganisms will enter the bone, and it will stay there. So it will lodge in the bone, and the microorganism will grow, result in increased pressure, and that increased pressure eventually will lead to the ischemia. So that's significant concepts that result in ischemia and vascular compromise of the periosteum. Periosteum, which is the lining that covers this very tight, strong, very thin layer that protects the bone, the layer that protective for the bone called periosteum. The area of the vitalized bone eventually separates from the surrounding living bone, forming what is called sequestra. So we need to know that the sequestra will continues to be an infected island of bone. So it's kind of like infected island in the bone, surrounded by the pus and difficult to reach by bone antibiotics. It's very difficult. So even when the use of IV antibiotics really won't get to the infected area, which is sequestrum, because that's protected. It's surrounded by an island that is of bone and the pus, and that protects the sequestrum from being in contact with any antibiotic. Won't be affecting antibiotics will not get rid of this or treat this sequestrum. So that's why it's always recommend that we do a surgical resection or removal of the sequestrum called sequestrectomy to get rid of and remove this isolated, protected island in the bone, which is infected area of the bone. So sequestrectomy will be the treatment, and then the strong antibiotics. So the sequestrectomy, which is the necrotic sequestration, is not resolved naturally or surgically. It may develop in a sinus tract. So the area will be surgically removed by this procedure called sequestrectomy. Now, acute osteomyelitis, which is the infection of the bone with a duration of less than 1 month of infection that would last less than 1 month. These are the side effects of the clinical manifestations of the disease process. So the infection of the bone that is spread hematogenously through the blood-borne through the blood, is more commonly by direct inoculation. Those with peripheral vascular disease, like patients with PVD, patients with diabetes, or patients who had underwent recent orthopedic surgery with the device implantation, they are at high risk. That hematogenous direct inoculation, that's what we meant by hematogenous spread or direct inoculation, that the patients with the peripheral vascular disease, patients with diabetes, patients with orthopedic surgical procedures with the orthotic or with the devices being implantable, like implantable orthopedic devices, they are at risk to develop the acute osteomyelitis. And then when the bone infection persists for longer than 1 month, or when the infection is refractory to initial antibiotic or fail to respond to the initial antibiotic, will be diagnosed with a chronic osteomyelitis. So it's either a continuous or persistent problem or process of exacerbation, remission phase. And then over time, the granulation tissue will turn to a scar tissue, and that will provide ideal site for further the organisms or microorganism growth. So over time, the osteomyelitis becomes more difficult to treat because of this concept, which is that the granulation tissue will turn to a scar tissue, providing an ideal site for the microorganism to further growth of the microorganisms. Treatment of the osteomyelitis will be heavily on, as we said, the sequestrectomy, debridement, and then surgical, and then the vigorous, prolonged IV antibiotic treatment is the treatment of choice for acute osteomyelitis, as long as the bone ischemia has not yet occurred, in the absence of bone ischemia. But we definitely are going to identify the microorganism by doing cultures or bone biopsy that should be done before the drug therapy is initiated. Identify the type of organism that has invaded this and caused this infection. And if antibiotic is delayed, then the surgical debridement and decompression are often necessary. When we discharge patients, then patients are discharged home or to home care with IV antibiotics delivered with either a CVAD or a PICC line. but they'll be on the antibiotic for months. Because patient will be on the drug in the home for like 4 to 6 weeks, or even sometimes longer than that, 3 to 6 months. Now, this is for the acute. In patients with chronic osteomyelitis, the oral therapy with fluoroquinolones like the ciprofloxacin, for example, ciprofloxacin, which is a fluoroquinolone, will be prescribed for 6 to 8 weeks instead of the IV antibiotics. That's for adults with chronic osteomyelitis. Answer to question number 1. B, which is blood culture. Osteomyelitis is a bacterial infection of the bone and soft tissue that occurs by extension of soft tissue infection. Direct bone contamination following the surgical procedure, or spreading from other infection sites in the body, like renal infections or any other infection from other systems to the bone. The positive blood culture would be reported immediately to the physician or to the nurse practitioner, so that the specific antibiotic therapy can begin or be adjusted based on the positive culture. A negative rheumatoid factor, RF factor, would be expected in the possible diagnosis of osteomyelitis. Alkaline phosphatase level of 60 is within normal range. ESR of 10 also is within normal range. Number 6. The answer to this question is continue antibiotic therapy for at least 3 months. Antibiotic therapy should be continued at least for 3 months. Some patients go home with an IV catheter in place, so the IV antibiotic can continue to be administered. So the early discontinuation of a prescribed antibiotic can allow infection to continue and may become chronic. Because the wound is already infected, most providers only recommend the contact precautions be implemented if the wound is drained, like, there's a drainage from the wound. So if the wound is drained, and clean technique be used for dressing changes. Pain relief can occur prior to the entire infection being eradicated. This should not be used as an indicator of a cure. Joint disorders: osteoarthritis, rheumatoid arthritis, gout disease. Osteoarthritis, and sometimes we mix up osteo with the rheumatoid, and we think it's the same, or sometimes it's interchangeably can be used, or these two disorders are completely different. They have different pathophysiology, different disease process, different disease progression, and this is the time when we have to differentiate between osteoarthritis and rheumatoid arthritis. So osteoarthritis is a chronic non-inflammatory joint disease. The hallmark of this disease is the degeneration of the cartilage. So a degeneration of the articular cartilage, hypertrophy of the bone margins, and changes that involve the synovial membrane. So it's progressive, degenerative, it's an age onset disease. It's non-inflammatory disorder of the diarthrodial, which is the synovial joints. Diarthrodial, which is the synovial. Slowly progressive, and more than 90% of adults are affected by age 40 and before. And so the incidence of osteoarthritis after 50 is twice as great in women compared to men. Now, this slide compares provides a comparison between rheumatoid arthritis and osteoarthritis in terms of the onset of the disease process, when it starts, then and the gender-related factor, risk factors, the pattern, the disease process, the what type of findings from the lab, like lab findings, diagnostic findings, so and therapy as well. So this is a great slide to review to have an idea on how to differentiate between osteoarthritis and rheumatoid arthritis. One of the significant things to identify here is that given that the osteoarthritis, the disease process, like involve it may involve just one side, one joint. However, the rheumatoid arthritis, it should be systemic disease. In other words, that all joints or both, at least both sides, symmetrical involvement of right and left side. If there's an effect, if there is a right wrist rheumatoid arthritis, then the left wrist also will be affected. Right hip, left hip as well. Right knee, left knee. But with the osteoarthritis, sometimes patients, even though some condition or cases or scenarios that you'll have osteoarthritis affecting both sides, but you may find a patient with right knee osteoarthritis severe and then mild on the left side, or just affect the right side. So it's more the rheumatoid, it's inflammatory systemic, so it should affect both sides equally, symmetrical, equally. So osteoarthritis may occur as an idiopathic or secondary disorder. So the idiopathic cause or factors unknown, but we have identified causes or events for the secondary osteoarthritis, like estrogen reduction at menopause, genetic factors, obesity, in which that it will result from the cartilage damage that triggers the metabolic response at the level of the chondrocytes. So there's a cartilage damage that will trigger the metabolic response at the chondrocytes. Genetic or genomic considerations. There was a classic study back in 2007 done by the Sunk, S.U. and K et al. And colleagues. What they found is that they identified a specific genetic link in osteoarthritis of the knee, and they reported that an increase in the DDR, which is discoidin domain receptor 2 expression of this gene in diseased joint cartilage was correlated with degree of tissue damage. So the authors concluded that this change occurs after the disease. They found that that this change occurs after the decline or decrease or reduction in proto-glycans from aging. So there are some association between the changes in the bone and the disease. So the studies being conducted or are being done or conducted to explore the genetic factor related to osteoarthritis. In other words, that there is some genetic predisposition or association between osteoarthritis and this gene or this genetic factor, which is specific to DDR2. This is a comparison between, or slight comparison between, the normal and abnormal or affected cartilage. How the normal cartilage is smooth, white, translucent, and then the affected ones, dull yellow, granular, and then softer, less elastic, less able to resist wear and tear. The body's attempt at repair, because there's always a wear and tear, even repairing of the teared or the abnormal or damaged ones. Now, the body's attempts at repairing the damaged cannot keep up with that destruction. So unable to keep up with the high rate of damaged or affected cartilage. So that's when the osteoarthritis would result. So that's from excessive use and putting more pressure and more load and more weight and more repetition of motion in the same joint at all times could result in osteoarthritis. So before we get to the manifestations, we'll just one last concept of about the pathophysiology and the changes that involve the joint from osteoarthritis is that the continuous changes in collagen structure. So it's all about the collagen. There's a continuous change in the collagen structure that result in the erosion and fissuring of the joint due to that collagen damage and cartilage. So the cartilage become thin, the central cartilage on the joint become thinner and less heavy or like very thin, and it may affect the joint by making the joint incongruent joint surfaces. In other words, it will result in uneven distribution of stress across the joint. And that will result in reduction in the joint motion. So the joint motion or range of motion will be more limited and restricted because of that, because of the cartilage damage, incongruent joint surfaces that will result in uneven distribution of stress across the joint. And that will reduce the range of motion of the joint. Then the inflammatory changes that will result in early, so that will lead us to the manifestations that the inflammatory changes that will result in early pain and stiffness. So even morning, they will also, like rheumatoid arthritis, also the same things that they will have experience that the severe pain will be early morning. So in addition to also the overusing the joint, when they overuse or repetitive motion of the joint will result in pain as well. So pain joint, that's the predominant symptom. Usually it's relieved by rest in early stages, not the advanced scenarios. And then it will, the pain will get, worse with joint use. So when we relax the joint, resting the joint, that will result in pain relief. So we can include also here localized pain and stiffness, joint and bone enlargement, and as we said, reduced or reduction in range of motion. crepitation, and from health assessment, you can refer to this from past or previous course of assessment about the crepitation, and that has to do with the cartilage damage. That sound you hear due to the cartilage damage. And again, the most significant part of this, the osteoarthritis affects joints asymmetrically. It should not be affecting. Patient may develop both joints on both sides, right and left hip or knee, but it's asymmetrical. Even if both sides are affected, but you'll find that one is more serious, advanced than the other side. But it's the rheumatoid arthritis that is symmetrical effect. Both sides should be, because that's systemic disease, systemic inflammatory disease, rheumatoid arthritis, the RA, in which that the patient will have asymmetrical effect of joints. So both joints symmetrically affected. By the osteoarthritis, however, joints affected asymmetrically. So osteoarthritis, clinical manifestations, affects the dip and PEP, so the distal interphalangeal and the proximal interphalangeal joints are affected, most commonly involved joints, DIP and PIP joints. The bearing joints, in which the two most commonly replaced joints are hip joints and knee joints. These are most or commonly replaceable or replaced joints, right? So that's the weight-bearing joints, because they are weight-bearing joints. So the deformities are the two common deformities that would result from the osteoarthritis. The first one, Heberden's nodes, and the other one is Bouchard's nodes. The Heberden's nodes affects the DIP joints, and the Bouchard nodes affects the PIP joints. Diagnostic studies for osteoarthritis. One of the diagnostic studies will be ENA, ESR, RF, which is rheumatoid factor, ESR, which is erythrocyte sedimentation rate, antinuclear agent. So the ENA, for example, is sometimes positive. So we have to be careful with non-specific lab tests, for example. Like rheumatoid factor will increase with age. The ENA is positive in about 5% of the population. The ESR also will be elevated with any inflammation. It's non-specific to the specific disease, but it's also will be elevated. The ESR will be elevated, in any inflammatory disease. So you will learn about the diagnostic testing and the interpretation of these tests results in adult L3 again. Osteoarthritis and treatment. So the goal is reduction of pain and inflammation. So the first treatment consists of we can also start with weight loss, physiotherapy, and low impact exercise. So for mild symptoms, we can start with or use the acetaminophen or NSAIDs, or sometimes intra or articular injection, corticosteroid injections for further pain control. It will be for longer kind of periods of pain management or relief over time. Can give like intra-articular, so it's an intra-joint, like you inject the bone, the drug into the bone, into the joint. And then joint replacement is used for severe osteoarthritis in patients who fail medical management and have marked limitation of their daily activities. So when the joint disease affects their daily activities, serious effect on their ADLs, it's severe osteoarthritis, and when it fails medical management, that's when replacement of the joint is a last resort, and that's when the patient is eligible for the joint replacement surgery. And that's also will be discussed in adult health 3 as well. So this is the collaborative or the management for symptomatic management, like rest and joint protection, heat and cold applications. IC would recommend it for when there is an acute inflammation, heat when there is, or heat applications when there is a stiffness of the joint. Drug therapy is based on the severity of the symptoms, salicylates and says opioid analgesics and so forth. You have the most effective drug for osteoarthritis is the DMARDs, the disease-modifying anti-rheumatic drugs. Disease-modifying anti-rheumatic drugs like hydroxychloroquine, Plaquenil, sulfasalazine, azulfidine. And then you have immunosuppressant and antibiotics. So under health promotion, we have many items or concepts to include as the health promotion maintenance to prevent osteoarthritis. And then the last intervention would be the surgical intervention for patients with osteoarthritis, which is arthroplasty. Arthroplasty, again, that will be this will be covered with much more details in adult health 3. So which is like osteotomy, arthrodesis, total hip replacement, total knee replacement, and then who is eligible for the drug, what's the goals of the joint replacement, and so forth, and then nursing and nursing interventions post, pre, intra, and post op. So the case study here on osteoarthritis, and the answer for this would be acetaminophen. So acetaminophen has an equivalent analgesic capacity to the NSAIDs, but it doesn't have an adverse effect on the GI system. The indomethacin is an NSAID with chronic, so that the chronic use will definitely and practically will result in a peptic ulcer disease. So this is the danger of the NSAIDs like the indomethacin. It may lead to result in the chronic use of it on empty stomach, especially on empty stomach chronic use, may result in peptic ulcer disease. So then the indomethacin should not chronically be used, should not be used like for long-term or chronic use. The answer for next question is C, that in which that the patient has progressive joint destruction and most likely has developed the osteophytes or the bone spurs in the joint of the patient's hands. So these spurs or these osteophytes are limiting the range of motion in these joints, and they will cause increased pain. So when these bony enlargements are found in the PIP joints, we said they call them, they were called or identified as the Bouchard's nodes. And with the affecting the DIP joints, they are called Heberden's nodes. The acute inflammation characterized by swelling, erythema, warmth, tenderness. Yeah, usually it's not commonly seen in patients with osteoarthritis, but it's more common in patients with inflammatory rheumatoid arthritis. So these signs will be more consistent with rheumatoid arthritis, not osteoarthritis, or even gout or septic arthritis. And when the metatarsophalangeal, these are the joints found in the feet, not in the hands. So this has to do with the anatomy. That's why it's incorrect. Rheumatoid nodules are subcutaneous nodules, also will be seen in patients with rheumatoid arthritis. The hyperextension of the PIP joints, it's like the swan neck deformities. Also, it is a sign of rheumatoid, which is usually advanced rheumatoid arthritis. Next question, the answer is D. The disease pattern of rheumatoid arthritis is usually unilateral and is seen in a single joint. And this is a question that is we are looking for the incorrect answer, the a need for further teaching. In other words, the incorrect statement, which is D, osteoarthritis is unilateral and usually affects a single joint, whereas rheumatoid arthritis is a bilateral and affects multiple joints. That this statement is incorrect. So it indicates the need the client needs further teaching. So always remember that rheumatoid arthritis symmetrical, osteoarthritis asymmetrical. So osteoarthritis, the case study number 2. All right. So currently this is a case study of a patient with osteoarthritis. All the indications or the history shows that there is an osteoarthritis. So worsening with use always is an osteoarthritis. But better with use with the joint, I mean the joint use. So when the condition is worse when with the use of the joint or worsening with the joint use, that's an indication of could be an osteoarthritis. But when the joint, it's better when we use the joint. So it's kind of, more, ambulation or walking or more of that, we exercise the joint. So it's then the pain is better. That is most likely rheumatoid arthritis. So which of this would be abnormal in osteoarthritis? Actually, none. You are not doing these tests because you expect anything to be abnormal in osteoarthritis. Quite the opposite. You're trying to rule out. So you are looking or doing these tests because if any of them is abnormal, it is likely not an osteoarthritis. Like, for example, the reason for the Chem7 test is to be careful about the use of the NSAIDs in patients with, because the NSAIDs result in renal insufficiency. You're trying to identify the abnormalities or the abnormal values or results from the long-term use of the NSAIDs. CBC, you're looking for the anemia, macrocytic anemia that may have been caused by an occult ulcers or peptic ulcer disease. So although daily NSAIDs or the NSAID use, daily or long term, led to an ulcer in about 10 to 20% of patients after like 1 year of using the NSAIDs. Only half of that, it's like 5 to 10% of them, will be symptomatic, and the other half will result or develop POD and bleeding from it. So what should all users of NSAIDs be taking along with the NSAIDs? So as a protective. So the question is looking for, how do you protect the patient from POD and peptic ulcer disease and bleeding and ulceration in the GI tract? So PPIs can be protected. So treatment, losing weight and exercise. The weight loss will decrease the stress on the joints, on the knees, especially nose and ankles, and it will also decrease the force on these joints, the exercise. So both of these interventions, weight loss and the exercise, they can slow the progression or the process of deterioration, but cannot reverse it. So these two interventions can slow the process of the deterioration of bone damage, but cannot reverse it. When the patient gets the joint, or the patient gets to the point that or the relief of the pain and immobility requires steroids, and there's also another medication called hyaluronic acid, usually injected into the joint, then we know that the patient should be referred to a surgeon, for orthopedic surgeon, for the suspected, or at least for replacement of the affected joint. So, which in other words, that the patient is not responsive, or the joint disease is not, or osteoarthritis is not responsive to the steroid therapy, to the hyaluronic acid injections, and so forth. So, patient's condition became refractory to these modalities, and at this point, referral to the orthopedic surgeon should be warranted for a suspected joint replacement procedure. So next is the rheumatoid arthritis disease, and in which it's a systemic autoimmune disorder. It's a systemic autoimmune disorder. So there's an inflammatory joint also an effect here, as inflammatory joint process or disease. In addition to that, it's systemic. It's an autoimmune in nature. It's an autoimmune because the antibodies have been detected to activate the inflammatory response in these joints. So these antibodies, rheumatoid factors, they will activate the inflammatory response in joints. And they found on how they, the theory that behind this, or which confirms the idea that this is an autoimmune disease and there is an autoantibodies, the presence of the rheumatoid factors, the RA or F test can be done to detect these factors. Rheumatoid factors that are present, which like antibodies like IgG and IgM, and that confirms that this is an autoimmune, or at least there's an antibodies. Autoantibodies are involved in the disease process. And then the extra-articular system manifestations like infections, pulmonary disease, the blood abnormalities, metabolic dysfunction, these are also consistent with with the concept or an idea or theory that the disease is a systemic autoimmune disorder. So autoimmunity, we see this, the inflammation causes the hemorrhage, coagulation, and fibrin deposition. So there are changes that will begin when a susceptible host experiences an initial immune response to an antigen. There is some susceptibility of the host to initial immune response to an antigen, and that's the basis for any autoimmune disease: antigen, and then susceptibility to initiate immune response against the antigen. This antigen will trigger the formation of the abnormal antibodies, which in this case, immunoglobulin IgG. And again, the lab values or results or analysis identified the RA rheumatoid factor or rheumatoid agent present in the blood of patients with rheumatoid arthritis. So the RA is characterized by the presence of autoantibodies, which is rheumatoid factor RF. So the RF and rheumatoid factor and the IgG, the IgG and rheumatoid factor both will form immune complexes. And these complexes will initially deposit in the synovial membrane of the affected joints. So we have an RF rheumatoid factor as an antigen. We have the autoantibodies, the IgG, RF with IgG, they will form immune complexes, and they both will initially deposit in the synovial membrane of the joint or the affected joint. So this complex will formation will lead to the activation of the complement. In other words, that will result in inflammatory response and process, inflammatory response and process. An inflammation, in other words. The autoimmune or the autoimmunity concept here, we said it causes hemorrhage, coagulation, fibrin deposition of the synovial membrane. The genetic factors or as an autoimmune disease, it will go through different stages. Like stage 1, early phase, which is no destruction or destructive changes on X-ray. You will see like evidence in the X-ray, like some evidence of osteoporosis, but it's an early phase with no significant destructive changes in X-ray. And when it's moderate rheumatoid arthritis, the X-ray evidence of osteoporosis present with some, with or without some bone or cartilage destruction, but there is no joint deformities, no deformity of any joint, some muscle atrophy present. Stage 3, the X-ray will reveal some cartilage and bone destruction in addition to the osteoporosis. There is joint deformity. There is extensive muscle atrophy. With the stage 4, which is terminal, there's fibrous or bony ankylosis. In other words, there's some deformities also associated with that. In addition to all in criteria number 3 or stage 3 is present as well, in addition to this fibrosis or bone ankylosis. So this is how the cartilage damage would result from these 3 processes, or the pathogenicity of how the cartilage will be destroyed by these 3 processes. And then a clinical manifestations, localized and systemic like fatigue, anorexia, weight loss, generalized stiffness, and then the joints, localized, affecting just the joints, and pain, stiffness of the joints, limitation of motion or limited range of motion, inflammatory signs and symptoms like heat, swelling, tenderness. The joint symptoms occur symmetrically and frequently. So the large peripheral joints like wrist, elbow, shoulder, knee, hip, ankle, jaw, as well as cervical spine. The joint pain increased with joint motion. So in other words, with the use of the increased joint motion, varies in intensity. And the joint pain may not be proportional to the degree of inflammation. The tenosynovitis, which is the difficult of, for patients to grasp objects, to hold the cup, to hold the pen and write, and to hold any object that's hard for them. That's difficult for them to grasp the object and hold it. The term called subluxation, this is a very important term, because subluxation, it's an atrophy of the muscle and destruction of tendons around the joint, which would cause one articular surface to slip past the other. In other words, that this looks like a dislocation, but it's not a dislocation of the joint. There is some. It's called, we call subluxation as an incomplete dislocation. You will see this more in children born with CDH, congenital dislocated hip, for example, when they are born with the CDH or CHD, congenital dislocation of the hip. Either it's complete dislocation or subluxation, which is incomplete dislocation. And that's because the atrophy of the muscle and destruction of tendons around the joint, which will cause one articular surface to slip past the other. Now, extracurricular manifestations, which is the manifestations that are involved, or the, which will involve and affect areas outside of the joints, other than the joints. Three most common types are rheumatoid nodules, Sjögren's syndrome, and Felty syndrome. So the extracurricular manifestations, we see rheumatoid nodules, which develops or would develop in about 25% of all patients with rheumatoid arthritis. Usually have high titers of rheumatoid factor, RF factor. It will appear as firm, non-tender, granuloma type mass or masses, and usually it's on the or over the extensor surface of the joints, like the fingers, the elbow, sometimes at the base of the spine or back of the head, are also common for older adults. The Sjögren's syndrome, which occurs in about 10 to 15% of patients with 10 to 15% of patients with rheumatoid arthritis, can occur as a disease by itself, or in conjunction with arthritis disorders like this one. There is a diminished lacrimation or lacrimal and salivary gland secretions. Decreased secretion from lacrimal glands, tearing and tears in saliva, decreased or diminished. Affect the eyes in terms of burning, itchy eyes, and the photosensitivity. The Felty syndrome occurs most commonly in patients with severe nodule-forming rheumatoid arthritis. So it's like an advanced severe rheumatoid arthritis. That's when patients may develop the Felty syndrome, and usually there is an inflammation or inflammatory eye disorders, inflammation of the eyes, splenomegaly, lymphadenopathy, and some blood dyscrasia like anemia, complications, flexion contractures, and hand deformities, which will cause diminished grasp strength. The patient's unable to grasp and hold the cups and pens and objects, and so it's very hard for them to grasp subjects or objects. Affect the patient's ability to perform also the self-care tasks. So the ADL becomes very challenging, very difficult to attain and do. The diagnostic tests or studies. So it's very important that we accurately diagnose the patient with rheumatoid arthritis for appropriate treatment or prevention of unnecessary disability. Patients with this disease, usually they have a positive rheumatoid factor, and it's been identified in about more than 80% of patients diagnosed with rheumatoid arthritis. They have a positive rheumatoid factor. The ESR, erythrocyte sedimentation rate, or C-reactive protein, CRP. They are general indicators of active inflammation. And X-ray, not specifically diagnostic for the disease, and the bone scans are useful in which that we can detect early joint changes and confirm diagnosis from the results of the bone scans. So the treatment, these are the goals and management of the rheumatoid arthritis. Plaquenil, or hydroxychloroquine sulfate, which is a DMARD disease-modifying antirheumatic drug, a drug for psoriasis, for inflammatory bowel disease. It's a TNF, tumor necrosis factor antagonist. So this drug was adalimumab, which is the Humira. So we have two drugs here. We have two prototype drugs, the hydroxychloroquine and the Humira. The Plaquenil, it's both are DMARDs, but Plaquenil relieves severe inflammation, arthritis, and lupus. So it's very effective for patients with SLE, the Plaquenil. The second, or the other one, which is the Humira, that is a TNF. It's a DMARD, but the mechanism of action or the classification is a TNF, but it's a DMARD drug as well. So both are DMARDs with two different indications. The Humira is more effective in patients with psoriasis, with IBD, in which that the drug, the indications here or we can go to before we go to gout, the black box warnings, the patients are increased risk for development of the serious malignancies and cancer, the latent infections such as the TB, tuberculosis, and hepatitis B virus also may become reactivated while on this drug. In terms of malignancies like leukemias, lymphomas, and other malignancies have been reported with this drug because it's a TNF antagonist, tumor necrosis factor antagonist. Gout, which is secondary gout, due to certain drugs, medications like diuretics, aspirin, cyclosporin, chronic use of alcohol. Diseases that affect uric acid metabolism. So the gout, it's a disease that affects the uric acid metabolism, like diabetic ketoacidosis, kidney failure, leukemias, hemolytic anemia, and other diseases. So diseases that affect the metabolism of the uric acid, the gout is one of them. Symptoms of acute attacks. Patients with acute attacks of gout will have swollen. It's usually it's a big toe or the uh, sometimes it's just just one joint, like the big toe or big toe or the forefinger finger, that it becomes swollen from the swollen tissue. So swollen, red, severe pain, very painful. So we talk about the big toe, the ankle, sometimes even large joints, um, other than fingers and ankles, and like the knees and elbow or wrist sometimes. So it may affect the small joint or large joint. But most patients, I would say, like of patients with gout, they always refer to the first sign, first joint affected by the gout is the big toe, swollen, red, um, tender, painful. Um, so, so the what triggers the disease is it's more dietary ingestion. So ingestion of alcohol, and sometimes dehydration and injury, but mostly it's the ingestion of certain types of, other than the alcohol, also there was the food that is high in purine. And we'll talk, you will when with the nursing interventions or implications and dietary modifications would be also included in a adult 3 interest as a content for the management of patients with gout and gout arthritis. So the pathophysiology, so it's a metabolic disorder that disrupts the body's control of uric acid production and excretion. So it's all about the uric acid metabolism, or the control between production and excretion. So it's related to the purine metabolism. Affected patients or patients with gout disease, they have an accelerated mode or process of synthesizing purine, or they have a problem with the poor uric acid secretion in the kidneys. So then they will end up with hyperuricemia, high uric acid in the blood, build up in the blood due to the decrease or poor excretion of uric acid by the kidneys. So the gout will occur when the uric acid concentration increases to high levels, right? To high enough levels to become like crystals, that the uric acid become crystallized like crystals. That's when the patient, or these crystals are insoluble, so they will precipitate or they will be deposited in the connective tissue throughout the body. So when these crystals occurs in the synovial fluid, the inflammation will begin. So that will trigger the inflammatory process in which that is called a gouty arthritis. Over time, these crystals or the crystal deposits in the sub-Q tissues will cause the formation of small white nodules or tophi, and these tophi will be visible throughout the skin. So the mechanism of the crystal deposition, we just described exactly what happens with the uric acid deposition, uric acid accumulation in the blood, and then the deposition of this into the connective tissue throughout the body, and then become crystallized. crystal depositions. So how to treat patients with gout? Gout or gouty arthritis will be treated with, these are the three, out of this table, I highlighted three commonly used, most important drugs in terms of used commonly used frequency and effectiveness. The allopurinol, like Xyloprim, colchicine, and propensid. Allopurinol, which is a drug anti-gout medication. It's xanthine oxidase inhibitor. It's very effective and it's an older drug, it's a very old drug to control the hypercalcemia, calciuria, so hyperuricemia, which is hyper uric acid in the blood or high level of uric acid in the blood, which will result in severe gouty attacks, and it will reduce the risk of acute gout attacks. So this is very effective drug for gout, and it's usually available as an PO, an IV drug. The IV administration of the allopurinol is usually reserved for patients with high uric acid levels resulting from the cancer chemotherapy. So patients with on chemo, they also end up with hypercalciuria or hyperuric acid levels in the blood. So this IV drug is usually reserved for that purpose or that specific group of patients with high uric acid levels resulting from cancer chemotherapy. The drug also, it may be used prophylactically to reduce the severity of uric acid associated with the antineoplastic and radiation therapies. Chemo, radiation. The drug takes 1 to 3 weeks to lower the serum uric acid levels to normal. So don't expect that, within like a day or two, or even few days, that will, result in reduction of or reducing the uric acid in the blood. So it takes 1 to 3 weeks to lower serum acid, uric levels, or uric acid levels in the blood. So patient and approach, the practitioner and saying that, nothing happened after 1 or 2 days. We have to educate the patient that this drug will have an effect, and it takes about 1 to 3 weeks to lower the serum uric acid levels back to normal. So one last thing about the allopurinol and the colchicine. Colchicine is usually prescribed for acute attacks. Allopurinol, long-term maintenance drug. Long-term maintenance drug, daily medication, prescription on a daily basis. Allopurinol during acute attacks, gout flares, when the prophylaxis or exacerbation, gout attacks, then colchicine can be given either PO or IV. fractures. So the last section or component of this lecture will be on fractures, and this is the time we're going to. All of this will be pathophysiology, which is the different types of fractures and different modalities, how to treat patients with different types of fractures. So fractures, so it's a disruption or break in the continuity of the structure of bone. Sometimes fracture results from trauma, like traumatic injury. Sometimes it's minimal, very minimal, tiny trauma, or even patients with for example, osteomalacia or osteopenia. They have very fragile bone, and they may fracture or even result in fracture from even turning in bed. So that affects, patients with certain types of bone orthopedic or bone disease called osteopenia or um, osteopenia. So so it can be, depends on the condition, either a traumatic injury or non-traumatic injury, like even turning in bed. Sometimes with this osteopenia, patient may develop fractures. So the fracture there are different classification systems for fractures. Can be differentiated or can be classified according to the anatomy, their anatomical position, site in the body. It can be also classified as closed versus open fracture. So we have, for example, we have transverse fractures, spiral fractures, green stick fractures, which usually results, and it's this very thin layer of the incomplete fracture, but it usually affects the children. Pediatric, usually, the trauma or falls result in incomplete fractures with one side splintered and the other side bent. So that is called green stick fracture, which usually pediatric, when they fall, when they have trauma, usually result in a green stick fracture. Comminuted, and that's when the bone or the fracture have several fragments, small tiny bones, and these fragments will be like kind of appear to be floating. Oblique, which is a fracture in which the line of the fracture extend in like an oblique direction, not straight direction. And then the pathologic fractures, that's a spontaneous fracture at the site of bone disease, and that's associated with, again, as we said, associated with like like advanced severe osteoporosis. So when patient with advanced severe osteoporosis, we turn the patient, we have to be careful because that turning, so have to use like, a pad or turning pad. So we have to be careful even with turning the patient from side to side, because that could result in fractures called pathologic fractures, because they have severe osteoporosis, or patients with children born with a osteopenia, severe a fragile bone. That also could result in pathologic fractures. And then we have the stress fractures, the stress fractures occur in normal or abnormal bone that is subject to repeated stress, repetitive motion, and stress on the joint, on the bone, could result in what's called stress fracture. Sometimes most of that is usually in the lower extremity in the foot. So description, we said there are different classification systems to classify fractures. Closed versus open, simple, compound, stable, unstable. So clinical manifestations, all fractures, they have in common all these symptoms: immediate localized pain, decreased function, the inability to bear weight and put weight on the affected part or the affected joint. guarding from pain. And not necessarily that the fracture has to be accompanied or associated or occurred with the deformity. So it may not be accompanied by obvious bone deformity. The healing process, involves 5 different stages. It starts with bleeding at the fracture end of the bone, and then hematoma, and then the hematoma, it will organized into a fibrous network, and then that will result in osteoclast invasion, invading the bone, and the lengthening of the collagen strands. Then after that, callus formation, the build up of the osteoclast, and then the last one is remodeling. These are factors influencing bone healing, positive factors versus the negative factors, and the manifestations of fractures. So to treat fractures, there are different modalities to treat fractures. And we'll also, again, this section will be covered in Delta 2, the orthopedic section. This one, which is the different therapeutic modalities to treat patients with different types of fractures. So we have something called reduction. And it's really important, critical that we understand what is reduction. What do we mean by reducing the bone? Reduction as an intervention to treat dislocation or fractures. So to treat fractures, we have to, it takes different levels to start from immobilization. So you can treat the fracture in which that both ends of the fracture that are not aligned, because the healing of the bone will result in deformity. Shortening of the leg, for example, if there is if there is lower extremity leg fracture, like femur or fibula or tibia, then that could result in that that we are without immobilization of the bone before the treatment, that could result in healing with displaced or improper positioning of the both ends of the fracture, and that will result in a short leg, or patient will be limping after the after healing process. So that's why immobilization is very important. We immobilize the fracture with with the cast, with splint, with immobilizer. So what is reduction? Reducing the bone. Before you immobilize the fracture, we have to make sure that we are reducing the bone. Otherwise, that reduction of the bone, it's the aligning both ends of the fractured bone against each other. So they have to touch each. They have, we have to resume the normal anatomy of the bone. That's what, that's the definition of the reduction. Bone reduction means resuming the normal anatomy of the bone, the normal anatomy of the fractured bone. So both ends should be touching each other with a normal, anatomy. So it can be surgical, it can be manual, it can be, so we have closed reduction, which is like manipulation of the hip joints of the neonate or the child, undergoing a congenital dislocated hip surgery, procedure, in which that we can do a closed reduction under the X-ray, under X-ray images, that we can do reduction just manually. It can be open reduction, which is a surgical procedure in which you have to expose skin, fascia, and muscles and get to the bone, and then we have to fix the bone. Then we are reducing the bone, means that both ends should be going to resume the previous anatomical position, or the anatomy should be resumed for the bone. for the fractured bone. That's open reduction. And then traction, that's when we apply weight to hold the affected bone in order to bring it to the normal anatomy. And then after that, we will implement another strategy, or intervention, which can be, so the traction is putting, or applying weights to pull the affected fractured bone to place it or put it back or resume normal anatomy. It can be skin traction or skeletal traction. Skeletal traction is an invasive procedure. A rod will be inserted in the bone, and I will get to some of these pictures about differentiate between the skin traction versus skeletal traction. But skin traction is non-invasive, but both tractions are applying weight to the affected fractured bone and to reduce it so it will go back to its normal anatomy, anatomical position, so we can intervene with, after that, like with surgery, with cast, or with, so the immobilization, we immobilize the bone should be immobilized. So we reduce it, put it back to normal positioning, or like the anatomical position, so it will heal normally, or without without long-term deformities after the healing process. So purpose of immobilization is that to prevent further injury, because sometimes the pointing tip of the bone, if it injures the blood vessel or nerve, or then it could result in serious traumatic injury to the nerve or the blood vessel. So we can prevent further injury. We can promote the healing and circulation, reducing pain, and we can correct the deformity. And we can use casts, splint, immobilizers, tractions, skin or skeletal, and we have also external fixators or external fixation devices. So the cast, there are different types of cast, and this slide identify or shows these different types of casts, in which the cast as a chemical material, it can result in what is called the cast syndrome, which is a condition in which there is the extreme or compressive and compression on the abdomen that will result in a complication called cast syndrome, in which the patient will have abdominal pain, abdominal pressure, and nausea, vomiting. Then that will be consistent with what is called the cast syndrome. So then there should be an intervention for this, which is the relief of the cast. We do something called cast window to relieve the pressure. So all nursing interventions and what should not to do or what should be done, and all the associated and relevant nursing implications about cast application will be also covered in adult health too as well. These are known or most common problems, complications associated with the injury of the musculoskeletal system. And one of the most important nursing interventions or nursing assessment tool or technique should be identified here. So we'll start with infection. The first complication of fractures in infection. And we know that the open wound and open fractures, in which the wound is open, and then there is the direct connection between the environment and the bone that puts the bone at more susceptible to be infected with osteomyelitis. So the high likely or the risk factor, the risk of osteomyelitis will be high in open wounds or open fractures. The second one is the most important one, and you have to highlight this and read about it, which is from the slides and textbook, as well in mid-search textbook, This is significant and more, the most critical condition that can be prevented. So preventable complication to a high extent by nurses, because that's based on the assessment. You can, when there's an increased pressure on any circumferential pressure, which is like around the lower extremity, around the upper extremity, or even around the chest, all can result in a decreased perfusion to the affected part. So the pressure, extreme pressure or high pressure on the what's called circumferential pressure, that is a significant factor to decrease perfusion. So the nursing intervention here is the assessment, and it's an assessment, which is a neurovascular that can prevent at least we can identify if there is a compartment syndrome at early on and early phase of the disease, of the complication process. At early phase of the compartment syndrome can be detected, identified, and it can be resolved. Very simple, as when we do the frequent neurovascular assessment, patient, for example, who had in which that we applied, let's say, cast or splint on lower extremity, and you are doing like every 30 minutes or an hourly neurovascular assessment, you have to check for CMSPP. You have to assess for color, motion, sensation of all the lower extremity in terms of the toes, right, and part of the foot. And here you are assessing for pedal pulses. The one that is exposed, that you're able to assess. Won't be able to access, for example, for this one, you won't be able to access the dorsalis pedis, but the tibialis you can. So you will be assessing the pedal pulses, color, motion, sensation. Any abnormal finding, bluish discoloration, edema, unable to assess for palpate for the pedal pulses, having the Doppler ultrasound and unable to access or hear anything, that's significant sign for compartment syndrome. So the 6 P's are significant. Patient will also disclose and also will complain of paresthesia, pain, pressure. So the 6 P's are consistent with compartment syndrome. And long term or the chronic, within a day or two, compartment syndrome undetected, unresolved, untreated, or not taking care of the compartment syndrome can result in a significant loss of blood supply, necrosis, and amputation. So that's why compartment syndrome is it's a nursing responsibility to identify them at an early stage and to be prevented, and to 100%, I would say, preventable. And we can prevent patients from losing their limb, or amputation can be prevented if we detect the compartment syndrome. So compartment syndrome can result from pressure from either inside or outside. So even from pressure from outside, we said like splint, cast, or any application that will put pressure on the extremities or the circumferential pressure that will result in decreased perfusion, that could, that's an example of outside pressure. Inside pressure, like compartment syndrome from the inside pressure, can be from like internal bleeding. Subcutaneous, like edema or enlargement, pressure and fluids or blood or under the skin. So that could result in pressure also against the blood vessels. So that will be bleeding or edema. That's an increased compartment content. Decreased compartment size, that's from the pressure of splint or cast or dressing. Sometimes even you apply dressing after wound treatment, and you apply the dressing and the dressing is too tight. That could also result in E compartment syndrome due to decreased compartment size. So the 6 Ps are clinical manifestations, and that's how you are going to identify this at early stage or phase of the disease process or the complication process. And you have tools. The basic tool is the neurovascular assessment, CMSPP. According to the protocol, follow the protocol, 30 minutes, 1 hour. You have to check, and make sure that there is none of these 6 Ps are evident or present. Fasciotomy can be one of these collaborative care, other than loosening or removing the bandage or any or creating any bivalve in the cast, or like a window in the cast. Also, traction can be an intervention to reduce the weight, so to reduce weight reduction, or surgical decompression, like fasciotomy. Removing the fascia can resolve some of this. If there's any pressure on the blood vessels and nerves, and the fasciotomy can relieve this pressure. VTE, venous thromboembolism, another complication expected from the fractures. The fat embolism syndrome, which characterized by the presence of fat globulus. The pathophysiology behind this is still unclear in terms of we don't have complete and clear understanding of how this or the pathophysiology behind the fat embolism. Have only theories that would explain the fat embolism syndrome. And one of the theories would include that the fat or the globules, which is the fat molecules, will enter from the bleeding, from the fracture, will enter the blood vessels, and that will result in fat embolism. And in which that, who would be at risk for this? Patients with fractures of the long bones. And the tissues that would be most affected by the fat embolism would be lungs, brain, heart, kidneys. So the last content or concept or part of this content would be the amputations, which will be also covered. Amputations will be covered in adult health too. And the last part of this would be questions, and I'm going over some of the questions. So the answer for this one is C, decreased sensational distal or sensation distal to the fracture site, because that's the sign of compartment syndrome. Number 7, B, which is the correct answer, B, call provider at once if you experience apprehensiveness, shortness of breath, fever, or palpitations. And this is a question about the fat embolism. So fat embolism, which is a complication of a long bone fracture, signs and symptoms will include all what's just under B, what described under B, which is apprehension, altered mental status, respiratory distress, tachycardia, tachypnea, fever, and sometimes petechiae, like reddish spotty spots on the skin, petechiae over the neck and upper arms and chest. Coughing and deep breathing exercises can help prevent other complications of a long bone fracture, but have no effect on the fat embolism. The client would also be instructed to drink plenty of water or fluids to stay well hydrated, but this will help prevent embolic complications. So, and this will conclude the lecture today.